Hey podcast listeners, Fawaz Murthy here. Welcome back to the Neurocritical Care Society podcast. Despite years of effort, intracranial hemorrhage remains one of the most devastating forms of stroke, with hematoma expansion occurring in approximately a third of patients and has been strongly linked to poor prognosis. Although the precise mechanism of hematoma expansion is unclear, it may be attributable to a long list of potential predictors ranging clinically from the severity of consciousness disturbance, blood pressure, blood glucose, the presence of coagulopathies, and inflammation, to radiographic predictors that may include baseline ICH volume, the presence of intraventricular blood, the modified spot sign, and the swirl sign. David Rowe and colleagues managed to potentially add blood type to the ever-increasing number of predictors of hematoma expansion in their recent publication in the Neurocritical Care Journal entitled ABO Blood Type and Hematoma Expansion After Intracerebral Hemorrhage, an Exploratory Analysis. I hope you enjoy this episode.
Thank you for listening to this edition of the Neurocritical Care Podcast. I am Chris Zamet, Assistant Professor of Emergency Medicine, Neurology, and Neurosurgery at the University of Rochester, where I'm an emergency physician, neurointensivist, and acute stroke provider. Today we are delighted to have Dr. David Rowe from Columbia University in New York with us. Dr. Rowe, thank you so much for being with us this morning to discuss your work.
No problem. Thanks, Chris, for having me. Appreciate it.
Absolutely. To start off, actually, would you mind telling us more about yourself and what your burgeoning academic interests are?
Sure. Just to kind of preface, I'm a neurology-trained neurointensivist. I'm an assistant professor of neurology at Columbia, and I currently attend in the neurosciences ICU at the Columbia University Irving Medical Center. My current research and academic interests revolve primarily around studying functional coagulation and transfusion medicine and acute brain injury, and specifically, we're focusing on intracerebral hemorrhage.
Great. Well, we look forward to your insights from this recent paper. So to start us off, what is the question that you sought to ask with this paper?
So for this paper, we really wanted to just take a first initial simple exploratory look at whether there was an association of ABO blood type with hematoma expansion after intracerebral hemorrhage. Great.
What prompted this exploration? Why would there be any association between blood type and hematoma expansion?
Sure. Yeah, that's a great question. So I think, just to kind of give some background, I wish I could say that this was like a topic that I'd been thinking about for a while. But to be honest, this was more of like an organic, fun product of some casual discussion that was occurring from like a separate project that I'd been working on. So I've been working and collaborating with a multidisciplinary group of coagulation and transfusion experts here at Columbia. And one of the collaborators, Dr. Andrew Eisenberger, he's one of our really smart clinical hematologists here at Columbia. He just kind of casually asked in passing as we were leaving a meeting one day, just, have you looked into ABO blood type? And like I sheepishly, to be honest, said no because I had no idea where he was going with this. And then he was gracious enough to kind of give me a little bit of background where there's a little bit of evidence out there suggesting that blood type has a role for cardiovascular disease and thromboses. And he specifically explained that patients that have non-O blood types, meaning that if you have type A, type B, or type AB blood, they have an increased risk of thrombosis, and that's potentially thought to be driven by those patients having increased level of von Willebrand factor and factor VIII. So, when I went back to look into this, there's actually a lot of literature kind of backing this up over the past decade. So I think this was something that was interesting for us to try to look into, to try to elucidate to see if this is something that would affect our patients.
Gotcha. In that background, how much of that background work had been done in the acute neurologically injured population?
So yeah, that's a great question. So there is some work, maybe a couple papers that are out there studying this specifically in ICH and subarachnoid hemorrhage patients, but there is kind of a bigger push, I think, in ischemic stroke to look at this, but really there hasn't been too much looking at this specifically for hematoma expansion, which was the question that we looked into.
Okay, great. So as part of this exploratory analysis, can you walk us through how you sought to answer this question?
Sure, yeah. So for our database here at Columbia, I was privileged enough to work with this data set that had been ongoing since 2009. There's something called the Intracerebral Hemorrhage Outcomes Project, otherwise known as ICHOP here. It's our single center prospective cohort ICH study, and it's been ongoing since 2009. We have about 800 patients enrolled, and with that data, we collect demographics, baseline characteristics, neuroimaging data, lab test interventions, complications, and outcomes. The thing that we didn't previously collect was blood type. So with this data set kind of already in hand, we look to specifically query this to try to assess that question of, is there an association of the exposure variable of blood type to hematoma expansion? to give you a little bit of a background into how we grab blood type as an exposure variable, because it wasn't readily available in the actual data set, we retrospectively went back and kind of pulled it for all our patients. And luckily for us, our clinical practice is to obtain a type and screen immediately for all our ICH patients in preparation for a potential transfusion need. So we were able to essentially get it for almost all our patients with the exception of about 15, I think. And when we tried to look at how to characterize blood type as an exposure variable, that was a little bit more of the tricky part. Most studies have used blood type as like a binary variable, meaning that they look at it as like O versus non-O blood types. And as you know, von Willebrand factor and factor VIII, the kind of potential drivers of the association in population-based study of thrombotic risk in the non-O patient population, those are acute phase reactants. So, I was a little concerned that with somebody that was with an active disease process, would this hypothesis hold up? So we wanted to additionally look at blood type as a categorical variable, and we used blood type O as a reference. This kind of mimics some work that's been out there in the genetic field for blood type.
Great. So you mentioned that basically this is a group of ICH patients who are admitted to your institution who had a blood type. Can you tell us a bit more about the inclusion-exclusion criteria used?
Sure, yeah. So we wanted to really focus on looking at our outcome variable of hematoma expansion. So because of that, we really made sure that the patients that we were looking at were those that had the available neuroimaging data to be able to calculate hematoma expansion. So we essentially looked for all patients that presented within 24 hours of symptom onset in order to make sure we're capturing the highest risk patients for developing hematoma expansion. And then we also had to obviously include patients that received a baseline admission CT scan and then a follow-up CT scan within 24 hours was the cutoff that we used for this study. In terms of other exclusion criteria, we did exclude patients that had secondary ICH, so we were looking really just primarily at patients with primary ICH. And then on top of that, we excluded patients that would potentially confound results by having a surgical intervention prior to the final stability CT scan.
If you don't mind, I'd like to just discuss a little bit about some of the considerations on an inclusion-exclusion criteria. I know for me, whenever I'm trying to consider the cohort of patients I'm going to include in an investigation, I kind of grapple with this a little bit, and especially in the ICH population. Can you provide a bit more insight on the decision to exclude those with a secondary cause from ICH? I think with the idea that probably some people would hope that there would be, in the end, not be an imbalance in the secondary causes ultimately across the blood type groups. But certainly we also could take into account that secondary causes of ICH would behave differently than non-secondary causes like hypertension and whatnot.
Yeah, no, I think you kind of hit the nail on the head there with kind of our concerns about including secondary ICH just because, it's like a wastebasket term of, essentially anybody else that doesn't have small vessel disease. And for our cohort, we have actually a decent amount, about 150 patients or so, if I remember right, that had secondary ICH. And because of kind of the well-known differences in outcome for patients that have secondary ICH compared to primary ICH, we wanted to kind of eliminate that natural confounder out of there. We wanted to kind of keep the cohort similar to what we see in clinical practice and also in like a clinical trial setting to see if there was like more of a focus where we can use blood type as something in those settings. So that's kind of the main driver why we excluded secondary ICH. And obviously, the majority of the patients that we see that present with ICH, they tend to be all primary ICH. So really those were kind of the multiple factors of why we decided to exclude those patients.
Any thoughts or comments on using a certain threshold of time since onset or time since last known well as another way to include or exclude your cohort with the idea that those who present a bit later are going to be much less likely to have hemorrhage expansion?
Yeah, exactly right. So I think for most of the studies that have been out there for hematoma expansion, usually 24 hours is the cutoff just because, like you said, the primary burden of hematoma expansion happens in that first day. That's a little bit tough for a lot of tertiary referral centers because a lot of your natural patients that come in are from outside hospitals. So the time from symptom onset to your admission CT scan is naturally just going to be a little bit more delayed. And that is something that you inherently will have to deal with. So, just using the 24-hour threshold for us was just so that way we can mimic prior studies. But, I think if you extend it past that, you're going to be potentially diluting out your sample by having essentially patients that don't develop hematoma expansion because of that. And then if you kind of shorten that time window, you're going to be eliminating a lot of patients just because of the natural nature of like who comes into our ICU. And then on top of that, it'll be difficult to really kind of nail down like an actual clear symptom onset time for a lot of these patients, which is a big limitation for a lot of these analyses.
Thanks for those insights. So, and to summarize here, so overall, you've got a cohort of primary ICH patients, so no secondary causes, who had a blood type and have a follow-up head CT and were treated within 24 hours. Does that sound right for your cohort?
Yeah, that's correct.
Do you mind sharing with us what you found, starting with any differences in the baseline characteristics of the groups?
For our manuscript, we identified 272 primary ICH patients that had available blood type data and reliable hematoma expansion data. When you kind of look at the distribution of blood types in our cohort, we found that the majority of our patients were type O blood, about 54%. The next most frequent blood type was type A at 30%, and then type B was 13%, and type AB was the minority at 3%. When you kind of look across the groups, there really weren't any striking differences in kind of baseline characteristics. There were some differences in race, which is something we kind of expected up front. But then in terms of other factors that potentially could be a confounding factor for hematoma expansion, there wasn't any differences in medication use and antithrombotic medications, either with antiplatelets or anticoagulants. The baseline ICH volume was essentially very similar. There were some mild differences in ICH location, but those weren't significant. There also was a little bit of a trend for differences in systolic blood pressure across the groups, with actually type B blood having higher blood pressure on admission. But other than that, the groups are pretty well balanced, and there were really no clear abnormalities or differences in standard coagulation tests like the PT, PTT, INR platelet count across the groups. When we actually looked at the results, when we looked at the association of blood type to hematoma expansion, we were, to be honest, a little surprised initially when we were looking at blood type defined as a binary variable. Although the confidence interval estimates were imprecise, there was an association of type O blood having actually less hematoma expansion compared to the non-type O blood. So then when we did additional analysis looking at blood type as a categorical variable, we found that this association was actually being driven primarily by patients that had type B blood. These patients were having significant increased odds of having hematoma expansion, and it was about a 2.8 greater odds of hematoma expansion specifically. Adjusting for baseline ICH volume, time to admission CT, and anticoagulants, this was something that we found that was significant. And then given kind of the intergroup differences that we talked about in Table 1, though there were nothing that was statistically significant, we made sure that we did sensitivity analysis adjusting for age, race, sex, systolic blood pressure, and location. We found that the estimates were still pretty much similar to what we saw in the primary analysis.
I think, as you began to mention, this is a bit opposite from what might have been hypothesized going into this project. Is that correct?
Yeah, exactly. I think, if you take the observational data and the population-based data that was out there before this with the kind of the association of non-O blood types having increased thrombotic risk, kind of the natural hypothesis would be that patients with type O blood would have potentially increased hemorrhage risk because of the lower levels of von Willebrand factor and factor VIII. So, we were a little bit surprised initially, but, again, kind of going back to the whole concept of, is von Willebrand factor and factor VIII an acute phase reactant? Is this the primary driving factor? This was something that we were initially concerned about. That's why we looked at this and looked at blood type as a categorical variable to make sure we weren't missing kind of additional signal.
Any additional comments on your findings?
We did an exploratory additional analysis to look at whether or not there's an association of blood type on clinical outcomes, and we weren't able to find an association. I think that was pretty clearly due to the fact that we had an underpowered sample where, our blood type distribution kind of prevented us from accurately looking at that, particularly with kind of the lower numbers that we saw in our type B and type AB blood types. So, we couldn't make a definitive statement on association with outcome, obviously, because of those limitations. I think the other limitations that are worth mentioning outside of just our smaller cohort size is really just the more granular data that I think would be necessary to kind of really assess why we're finding the signal that we have. And I think the first foremost thing that we have to think about is really we don't have genetic polymorphism data with our blood type. We're really just looking at type and screen data where you essentially assess somebody's phenotype for what blood type they have. But, as you know, the blood group can differ amongst the specific phenotypes. So a patient with type A blood can actually be AA blood or AO blood, and then a patient with type B blood can be BB blood or BO blood. So these are things that we obviously were not able to assess in our cohort. And also, I think it's worth mentioning the limitations of the use of relative hematoma expansion thresholds, what we define as hematoma expansion. We didn't use the classic greater than 33% or greater than 6 mLs of growth to define hematoma expansion. And while greater than 33% was what we used as our definition. And while that's kind of a commonly utilized and well-established threshold, it's unclear if that use of that definition could impact kind of what our findings were on outcome and whether or not this is a reliable endpoint measure for us from like a clinical relevance standpoint. And I think the last limitation worth mentioning is that we obviously didn't have any other coagulation tests that would be of interest, like von Willebrand factor, factor VIII, or something more exotic, like looking at the endothelial markers like the selectins or the ICAMs. Those are other things that we obviously did not have for our data set. And then we didn't have other potentially more novel modalities of functional coagulation tests like the viscoelastic hemostatic assays, which are whole blood tests, which actually do use erythrocytes in their contribution to coagulation. So that's something that we didn't have data for at the time. So those are all things that did limit the next steps in interpretation for the data that we had.
One question I would like to ask, you mentioned about that each of the blood types themselves, that there's some heterogeneity and some subgroups within them. I take that to imply that it is the actual blood type itself that may induce differences in coagulation. Or is it meant to imply that perhaps that there are coexisting genetic polymorphisms in those with these different subtypes that impact someone's functional coagulation status as opposed to there being a direct effect of the antigen, or could it be both?
Yeah, that's a great question, a tough question that I don't think I have the answer to. I think that's really kind of the next direction of where we need to take this research. And I think the first and foremost thing that I think is worth kind of investigating is whether or not our findings are real. I think when you have exploratory data like what we have, which is kind of unique and somewhat of an unexpected signal, I think we really have to create external validation first. Because, obviously with the limited data, we really can't make any mechanistic interpretations on what we have. And I think having that external validation data set would be required prior to us kind of making this deeper dive into exactly those hypotheses that you mentioned. I think those are all very, very compelling questions. Like, is ABO blood type and coagulopathy, is that relevant for ICH patients first off? And then if it is this something that is essentially like an epiphenomenon? Is it really not the ABO antigen itself? Is it really just kind of its association with von Willebrand factor, factor VIII, or maybe some other endothelial markers that's driving coagulopathy? Is it worth positing that blood type antigen plays a role in and of itself in hemostasis? I think that's a really interesting question that is something that hopefully we can start investigating into, because obviously, as you know, the blood type antigen is probably the largest studied antigen on the erythrocyte membrane, but we really know its role only for like transfusion reactions. And I kind of find it a little bit difficult to believe that evolutionarily the blood type antigen is just there to create a transfusion reaction for somebody else.
Is there any pre-existing data using viscoelastic hemostatic assays like TAG-ROTEM to demonstrate any differences in healthy controls based upon blood type?
That's a great question. I think from my understanding, there really hasn't been too many ROTEM tests ROTEM specifically tests for ABO blood type. For TAG, I'm not too sure if there's anything that's out there. There has been, I think, some literature out there showing potentially blood type and von Willebrand factor effects on your partial thromboplastin time. So if that's the case, this is something that maybe would be worth investigating for, the whole blood viscoelastic assays. The only caution that I have with that is, we've had discussions about this in the past about these tests being kind of low shear condition activators of the coagulation process, and that doesn't really represent what happens in vivo with the actual shear conditions in the blood vessel. So despite the VHAs being kind of a really good new leap in the right direction for studying coagulation, it may still be limited where the shear conditions and those types of like endothelial interactions that may be actually driving the interaction with ABO blood type and coagulation may not be captured by those tests, but I think it's definitely worth investigating further.
Great. Thanks for those insights. Certainly valuable in developing a bit more of a nuanced understanding of like you said, the TAG-ROTEM tests that are certainly expanding in popularity and a lot of nuance to begin to tease out. Any other final take-homes, either for clinicians or researchers or anyone else that you'd want to share from your work?
Sure. Yeah, I think take-home message for clinicians, this sounds obviously like a very simplified statement, but I think, the real take-home point from this is really just that coagulation after ICH is super complex. I think, we're doing our best to try to use the current diagnostic and treatment modalities that we have to provide the best clinical care for our patients, but I think there's still so much that we don't understand about what happens from a coagulation standpoint after ICH, especially at what happens at the local endothelial level at the site of injury. And I think we kind of need to investigate this further to be able to provide and implement the best tailored treatments and the strategies going forward. In terms of like a take-home message for researchers, I think I would love to see if we could externally replicate this type of data in another cohort. Because this signal was a little bit unique and unexpected, the external replication I think is required for us to see whether or not this is something that, a deeper dive should be taken for to kind of look at the importance of blood type on coagulopathy. I think that's something that definitely is worth looking into and hopefully in the future.
Outstanding. Well, Dr. Rowe, thank you so much for taking time this morning to discuss this work and your knowledge and insights into this topic with society, and look forward to your future work in this area.
All right, sounds good. Thanks, Chris. Thanks for having me. I appreciate it.
The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Romani Ballou, Mike Brogan, Josh Levine, Sarah Stern-Nezer, Benjamin Miller, Storeen Shepard, and Chris Zammit. Our senior producer is Jim Siegler. Our administrative staff include Angel Gindel, Sarah Mimmin, and Becca Stigman. Music by Lee Rosever under a Creative Commons license. The Neurocritical Care podcast series is available on NCS On Demand and wherever you may listen to your podcasts. For more information, please follow us on Twitter at Neurocritical or Facebook. I'm Fawaz Al-Mufti, and thanks for listening.